Welcome to today's ADEA webcast titled The ACA Through a Post-Election Lens. It's now my pleasure to introduce our host, Dr. Eugene Anderson, who is the Chief Policy Officer and Managing Vice President of the American Dental Education Association. Dr. Anderson leads the ADEA Policy Center. The ADEA Policy Center provides evidence-based research and analysis, collaborative advocacy, and thoughtful leadership. The ADEA Policy Center works through 4 targeted portfolios, including access, diversity, and inclusion, advocacy and governmental relations, educational research and analysis, and institutional capacity building. We are pleased that Dr. Anderson could join us to host today's webinar. Dr. Anderson, welcome to the program.
Thank you, Kurt. We're fortunate to have with us today Dr. Peter Damiano as our leading conversation expert for the webinar. Currently, he serves as Director of the Public Policy Center at the University of Iowa and Professor in the Department of Preventative and Community Dentistry at the University of Iowa College of Dentistry. Thank you, Dr. Damiano, for joining us today. Also joining us today is Dr. Evelyn Lucas Perry, who serves as the ADEA Director of Public Policy Research in the ADEA Policy Center. Today's webinar will focus on the Affordable Care Act, which will be referred to often as the ACA. Passed back in March of 2010, the ACA represented a significant attempt to reform the U.S. healthcare system. Its stated goals were to reduce healthcare costs and improve patient health outcomes and experiences. Over the course of the next hour, our participants will learn about the various components of the ACA related to access to oral health care and the ACA's impact on academic dentistry. We will also do a little foreshadowing in what we might expect with the new Congress when it convenes in January 2015. But before we talk about the potential impact of the ACA and the midterm elections, let's start with a basic overview of the Affordable Care Act. We're going to play for you a portion of a video created by the Kaiser Family Foundation. The video succinctly highlights the main aspects of the ACA.
Let's face it, folks, the new healthcare reform law is complex. It runs about 1,000 pages, even in tiny print, so it's no surprise that very few Americans have actually read it. But it's about to affect all of us, and many have been wondering what it will mean for our health, our wallets, and our country. Let's say we take all 310 million Americans and squish us down to just 25 people. Yep, each of these folks would represent about 12 million of us, and this is pretty much what we'd look like. Polls show about 3 out of 10 of us say health care reform will make us better off. A similar number say worse off. And a similar number again say it won't make much difference at all. Some of us don't know what to think. I guess you could say we're kind of split on this one. But no matter where you stand on the issue, it's likely you're thinking, hello, I got some basic questions still unanswered here. And you deserve real answers, not the partisan rhetoric and spin we've been flooded with. So let's break down what the reform law does and doesn't do and what it will cost. If you want to read the whole law, go ahead, but watching this video is the next best thing. Ready to jump in? Let's begin with the problems in our current healthcare system. Problem number 1 is what problem number 1 usually is: money. Most people agree that health insurance policies are too expensive. For a family, the average premium is almost $14,000 a year and growing. Premiums have doubled over the last 9 years, ballooning way faster than inflation. Plus, our population is aging, meaning more people with more health problems. So health care costs are the fastest growing part of the federal budget. The second problem is that the system is full of holes, like the fact that people buying insurance on their own can be turned down for having a pre-existing health condition. Small businesses may be charged extra if some of the workers are sick, making insurance unaffordable. And some insurance policies have a lifetime limit on benefits. After that, you're out of luck. That means some of the people least likely to have coverage are the ones who need it most. Nice, huh? High costs and holes in the system mean more than 1 in 7 of us have no health insurance to protect us at all. Many more struggle to pay their bills and can only afford bare minimum policies that may not cover much. High cost to households, strain on the federal budget, and people with no protection. It's easy to see why many people were looking for something different. So here's what the health reform law plans to do in its first phase between now and 2014. To start dealing with cost, insurers will be limited in how they spend our premium dollars. If they use too much for administrative cost or profits, they'll be forced to give some of it back through rebates. This won't stop premium increases, but it may help some. Some services will become free in all new private insurance policies and in Medicare, preventive care like screenings and vaccinations. People on Medicare, because they're over 65 or disabled, will get more help with their drug cost. Young people can save money and stay insured by remaining on their parents' policies up to age 26. And some small businesses will get tax breaks to help them pay for health insurance for their workers. And the holes, well, some will be closed starting now, too. Lifetime limits on health coverage will be gone, whether you buy your insurance on your own or get it from your employer. And it will be illegal to turn kids down for having a pre-existing health condition like asthma or diabetes. Of course, some adults who buy insurance on their own will still be getting rejected between now and 2014. Those who do can enter something called a high-risk pool run by the government. No, it's more like a policy that covers the sickest uninsured people, meaning it's riskier for insurance companies. That's why the government will chip in some money to bring down the cost. Some say these high-risk pools will help a lot of people. Others say the pools will still be too expensive and may not have enough government money to stay in business until they're replaced by something better in Phase 2. On New Year's Day 2014, some big changes kick in. First, let's look at how the law makes health care more affordable. Medicaid will be expanded to cover all low-income individuals and families in every state. And depending on what you make, if you lose your job or your employer doesn't provide decent coverage, you may get a health insurance tax credit. And while most of us will continue to get health insurance at work, just like now, if you don't have that option, you'll be able to buy coverage in what's called an exchange. You'll be hearing a lot about them, so let's stop and look at how they work. An exchange is like a virtual insurance mega mall. Based on where you live, you'll get an easy-to-understand menu of options to compare plans in plain English, and the exchange makes sure insurance companies compete fairly under strict rules. The idea is that by giving consumers good information, a fair playing field, and access to lots of choices, competition among insurers will keep rates competitive.
Okay, that's right.
Now,
the video covered the main components of the ACA, including the establishment of health insurance marketplaces and coverage changes in health plans. The impact of the ACA, which is reshaping the entire healthcare landscape, is just beginning to be felt. So, Dr. Damiano, can you provide a brief assessment of the ACA's impact as we near the end of 2014?
Sure. Good morning, Eugene. I appreciate the opportunity to be here. I think these kinds of conversations are really important given the political rhetoric that surrounds sort of both sides of this issue. And, hopefully today we can sort of tease apart some of the pieces and parts, in a nonpartisan, non-political way. And while it's still early, in terms of the impact of this first year, I think it's important to just highlight a couple of things that were in this video and as we're moving forward. So first of all, there were a number of the pieces and parts of the Affordable Care Act that had already started prior to beginning of this year. And when you ask people about those, and we've done that in some of our studies and others have as well, things like getting rid of pre-existing conditions, annual maximums, those things are all very popular with people. And then when you ask them about, though, are they supportive of Obamacare, the Affordable Care Act, you get differing kinds of things. But the health care cost issue, obviously, is very important. The holes in the uninsured, I think, is also a really important one to have an understanding of as we go into this discussion, in that the 50+ million people who are uninsured in the United States, these are 80% of them are working people and their families. So these are people who are working at what I tend to call the wrong jobs, are working at, many are working full time, but they're working at lower wage jobs or service sector jobs without insurance and don't have the resources to be able to buy private insurance. About 50%, or actually about 2/3 of them, make $50,000 a year or less, and right now an annual family policy costs about $16,500. So those are where the holes, when we think about that idea that they were talking about. So who are we trying to pick up with this? Again, many of these are working people, single adults in particular, that didn't qualify for Medicaid. The other thing, as we kind of move into this discussion, I think is important, is we often focus on the health insurance coverage part of this. And there's really two major aspects going on. One is the coverage piece, which to me is the relatively easier of these if we really wanted to, had both the political will and the desire. We could cover everyone with insurance tomorrow. We know how to do it. What we don't know how to do very well are the delivery system type changes, and how do we provide services to the high cost, high utilizers who tend to be people with multiple chronic health conditions, often physical and mental health components to those. And there's real opportunities for both improving quality and reducing costs if we can figure that out. Those are the real challenges as we move forward. So having said that, how do we judge what's happened so far after what people are mostly thinking of as the first year, and that's because of the first year of the individual mandate and the fact that everyone had to have insurance on the Medicaid expansion. And what I would refer people to is the Commonwealth Fund did a report that talked about their report card, things that they had established last year going in and what they would look for to see if it was effective. And there's a couple of those things that I think we can focus on here and just talk about a little bit. One of those is how well did the health insurance marketplaces work? And so, and from the insurance purchasing perspective, there were two components of the insurance expansion. One were the health insurance exchanges, the marketplaces, and that's where people would purchase subsidized private insurance. And then there's the Medicaid expansion. As we all know, in terms of how well the marketplace worked, the federal marketplace, the healthcare.gov site, had some issues when it was first getting started. But overall, by the time the open enrollment period got toward the end of March, it was actually working pretty well, and enrollment beat expectations. We'll talk about that in just a moment here. But then you had the 26 states that had their state marketplaces, and those were, again, a mixed bag. You had some like Kentucky, Connecticut, California that worked pretty well. You had others like Oregon, where they paid $43 million to Oracle and they never got a site at all. And some of those, like Oregon, then deferred to the federal site. And so did the marketplaces work as sort of one of the first measures we're looking at? Again, sort of a mixed bag. The second was, well, how many people ended up enrolling? And as I said, that actually exceeded expectations even with the problems of the initial healthcare.gov, where the initial estimate was that 6 million people would enroll in the private side, about 7 million, 7.3 million ended up enrolling. On the Medicaid side, it was estimated they'd be gaining about 7 million Medicaid expansion states in the first year. We actually got about 8 million. So enrollment for the first year, not too bad. Then the question is, were these people that were just shifting from one type of insurance to another, or were they actually gaining new coverage? And that's where the number of the uninsured was that affected. And initial estimates looked that between 9.5 and 12 million fewer uninsured there are now in the United States, with somewhere in the neighborhood of 42 million remaining. But it's a tough, and those are point in time kinds of numbers, and that's something to really kind of keep an eye on, so that it isn't just people shifting, but are actually gaining insurance who didn't before. And then the last one, it was pointed out in the video, is healthcare costs. Hard to say that the Affordable Care Act was the reason for all of the changes in healthcare costs are actually reductions, but we did have the 5th year in a row of 4% increase or less, and it was 3.6% just in 2013, the numbers that just came out about a week ago. So those are all very positive. Also, the costs for the ACA itself for this first year ended up being about $5 billion less than expected, which is very unusual for new government programs. Totaled about $138 billion according to the CBO report. And dental costs, overall, recent numbers that came out increased about 1% to about $111 billion overall. So on these measures, I would say step in the right direction, but still really early on to say whether this has been that effective or not. When we think
let me transition us here, because I know certainly we'd like to also delve into what impact the ACA should have on dental benefits. So can you talk a little bit about the essential health benefits and the inclusion of oral health care?
Sure. And so on the private side, you had a list of that all the plans that were going to be offered in the health insurance marketplaces had to have these set of services. And initially, it was very exciting that included for the child benefit that it was going to cover pediatric dental services. The way the interpretation of that ended up playing out, though, was that they had to be offered, but they didn't have to be paid for. On the Medicaid side, you had similar types of issues with Medicaid as you had before. So on the pediatric dental benefit, the way that it played out, in some places you had plans that they were actually embedded in a medical plan. Some of them that they were standalone plans that you could select them if you wanted to. And according to some recent numbers from the American Dental Association, about 88,000 children and about 1 million adults obtain standalone dental plans through the federal marketplace. The take-up rate being about 16% for kids, 19% adults. So it actually ended up picking up more adults than children, which is a little bit of a surprise because of the essential health benefits, thinking that it was going to be a real boon for children. When we think about that, then on the Medicaid side, although the proportion of children that are uninsured was lower, all of the children in states where there was a Medicaid expansion, or what they call the woodwork effect, which is children that were already eligible and now signed up because of the individual mandate, they all have mandatory comprehensive dental coverage. Now, you have to be careful. That doesn't mean access. That means they have financial access. They still have to be able to provide and find a dentist that would treat them with their Medicaid coverage, which in many states and many areas of different states is problematic. But the children were good. In terms of the adults, and you can see on the map here in terms of what states expanded Medicaid, the adult coverage is going to depend on what the states decided to do. Because as most of you are aware, adult dental coverage in Medicaid is an optional service. And so some states don't cover any dental for adults. Some have very limited, some have more comprehensive. And so it's a mixed bag in terms of the expansion of dental coverage for adults in Medicaid. But again, overall, it was a gain, but we'll have to kind of see how much.
So, Dr. Damiano, with these changes that have been taking place in insurance benefits and the expansion of Medicaid, what does this all mean for the actual impact on the delivery of oral health services?
Right, and that's the real, that other side of it, as I mentioned. You've got the insurance coverage, but then you've got the delivery system changes. And one of those is who's going to be available to see these people, whether it's the medical care, mental health services, or dental care. And many people thought, well, we wouldn't need as much on the safety net side if we're providing people with insurance coverage, because then they can just go to the private sector. But the capacity there is not necessarily adequate either. And in Massachusetts, when they did a similar expansion in the same way that the ACA was done, and Massachusetts did it back in 2007, they actually found that the need for the safety net, and for dental, for the most part, that's federally qualified health centers, actually went up rather than went down, because you're providing many more people with private insurance that can squeeze out the capacity within the private delivery side and then force people over to the safety net side. But for others, the safety net is actually a more comfortable place, might be a more local location, might be better in terms of cultural competency kinds of things. And so the community health centers are going to be playing an important role. Doesn't mean that there isn't going to be a role for the private sector, though, in seeing people who have gained coverage, because absolutely. And then the question is, on the delivery system side, the big change on the medical side has been the development of what are called accountable care organizations. And many of you are familiar with that. But there are other ways that there's medical dental integration that is being discussed or happening at different levels. The accountable care organization is the most formal arrangement where, and this started within the ACA, there was just a small component about Medicare accountable care organizations, which was really to try to introduce the idea of population health care into the mix and have healthcare delivery systems be responsible for an entire population of people, try to encourage the identification of those people who are the high-cost, high utilizers in advance, or once they've come in for care, try to, through care coordination, health coaches, other kinds of things, reduce rehospitalizations, emergency department use, and there's going to be a potential role for dental care. And this is a kind of a variety of different approaches that the medical dental integration can take, where it would just be a facilitated referral sort of on one end, where you might have an arrangement potentially, say, between an emergency department and an FQHC or even a private dental practice, that we have somebody come in with a dental problem, we're going to refer them out to hold down the costs of care in the ED, all the way to the other end where you might have dental clinics co-located or be fully integrated within the accountable care organization, and there's different kinds of risk arrangements and actually being a part of that. So there's a whole spectrum of different things that are being explored. Not a whole lot is being done yet, but there are things that are moving in that direction. I think there's things that we need to be sort of paying attention to. The big areas that people are talking about in terms of that oral health integration is that, number one, reducing emergency room costs by seeing these patients on referrals, ideally not just an ED diversion program where it's just to get them out of there, but actually getting them into a dental home where they're going to be able to have someone take care of their comprehensive dental needs. There are also discussions about clinical risk assessments being done in dental practices. In the dental Medicaid expansion in Iowa, that's a built-in component of the plan where the dentists do a clinical risk assessment. And then the key is going to be getting the information that's picked up, whether it's something about diabetes, hypertension, other things. The American Dental Association also did a report not too long ago showing the amount of cost savings that could be done if we did more of the screening for chronic diseases in dental practices, and then that integration through connected electronic health records, ideally, or other kinds of mechanisms where you'd be able to refer the people back and forth for really the total health of the patient, and developing this whole concept of a health home. And so a lot of these things is really going to be, pushing us for some significant change and some cultural changes, and everything from the interprofessional education component, but how it works out in practice. One of the reasons that this has been able to happen in the whole ACO development on the medical side is about 60 to 70% of physicians right now are employees in some sort of a broader practice arrangement. We don't have that high a proportion in dentistry, and so it's going to be a little bit more the way medicine was, say, 20 years ago to some extent, but because of the other changes, there's a chance that this whole thing could happen a lot more quicker. But the whole idea of whether it is group practices or just some sort of a facilitated arrangement, but looking at population health perspective, and that's, again, something different. We're not used to, and really don't even have a good sense of what it would mean. What's my population if you're in a private practice or you're in an FQHC or you're in a dental school? Who is our population? We're so used to kind of dealing with the people as they walk in the door, but how do we think about broader types of population health, whether it's on the medical or dental side? And then this again, making sure, as we all do as oral health professionals, that oral health is included in the whole broader concept of health. And some of the things that might be a little bit more challenging for us to try to do that are some of the different payment changes. Obviously, the majority of payment arrangements in dentistry is still fee-for-service. In these accountable care types of arrangements, they're moving the sort of the entry level, if you will, to something like that is some sort of a shared savings that if you can hold down costs, and I think one of the big differences between managed care in the past and what's going on now is that you have to meet some different types of quality metrics to be able to get that shared savings reward at the end of the year. But this could be moving towards risk-based contracting, where if you don't make that savings, that you'll actually lose money. And that's very difficult to implement, both on the medical side and the dental side, very different type of concept that we're used to. And the whole idea of accountability and paying for performance is not something that we really have had in any kind of a significant way in dentistry. We don't have diagnosis codes, which is one of the key components for actually setting up pay for performance kinds of things, but something that I think we're going to have to be thinking about both from a dental education and a dental practice perspective.
Thank you, Dr. Damiano. We're going to take a couple questions because certainly there is a lot of specifics regarding the ACA that we want our audience to understand clearly. Let me first ask, Dr. Damiano, you've lived in Iowa for how long now?
About 25 years.
Okay, 25 years. So what does this all mean on the ground locally in your community? What are you seeing? What are your neighbors who are just regular, everyday folks not in the healthcare system? What are they seeing? Can you just give us that example?
And Eugene, on the medical side or dental side or both?
Just touch briefly on both.
Okay. On the medical side, where I'm seeing the changes the most, and I don't think like most of my neighbors and people are seeing this, but it's the discussions that are going on within the delivery system. So you're having much more integration on the medical delivery system side and consolidation. So right now in Iowa, you pretty much have two delivery systems that have formed, one called Unity Point and one what's called the University Alliance, which is with the Mercies and Genesis and the Quad Cities, for those of you who are familiar with this part of the world, that are really going head-to-head and creating this hyper-competitive environment to try to get what are called attributed lives as a part of these accountable care organizations. I think there's some potential real positives with that. They're hiring care coordinators. They are trying to think about the population health, and I think there has been a really serious discussion going on within these delivery systems and a change. I don't think they know how to do it yet, and I think they'd be the first to admit that, but we just had a conference here about a week and a half ago, and the head of the Uniport delivery system was adamant that regardless of what happens in the future in terms of politically with the Accountable Care Act, with the ACA, that we need to keep moving in this direction from the delivery system side. But most people don't necessarily feel this. Even the members of a Medicare ACO, for example, don't necessarily know that they're in it. And even if they get a flyer that says that they are, they don't necessarily know what that means. But that's where I think the biggest change and the biggest challenge is. How that relates to dentistry, there's been some expansion. In states where there's a Medicaid expansion, Iowa being one of those, we have what's called the Dental Wellness Plan, which is a carve-out to Delta Dental, and it's an earned benefits model. And so there's experimentation going on, which is also really important to understand. The ACA is often sort of talked about as a federal takeover, if you will. What's really happening, in my opinion, and others, is that the experimentation that's happening at the state level is really where the action is. And it's happening all across the country and in different ways in every state. Iowa experimenting with this new dental program where when you first, and these are again primarily single adults, first get into the program, you're eligible for what are considered stabilization services, things like getting large fillings taken care of, getting extractions that are problematic. You come back for your first checkup within 6 to 12 months, you then become eligible for routine restorative care. The next 6 to 12 months after that, you come back, then you're eligible for crowns and partials and dentures. Experimental program to some extent. We'll be doing the evaluation of that, see if it works. But I think this kind of experimentation, it is really exciting to see what's happening, and then hopefully will spread across the country, identifying the things that do work.
So you bring up experimental programs. I know that there are provisions in the ACA for pilot projects, and so I think that relates to one of our participant questions. What are your thoughts on the use of mid-level providers, for example, dental therapists, within the guidelines of the ACA?
Yeah, I personally don't take a side on that issue, if you will, but I do think the idea of how do we provide the most efficient care and access to care to populations is going to be critical with whatever types of providers and what other types of settings. And that idea of everyone being able to practice to their highest level of their license, whether it's a nurse practitioner or PA, or states that do allow dental therapists or a dental hygienist or a dental assistant, I think is going to be really important to make sure that we have a delivery system that's adequate to match the needs and the demand.
Thank you, Dr. Damiano. For any listeners who recently joined the webinar, welcome to our program. Today's topic, the ACA, through a post-election lens, is being presented by the ADEA Policy Center, which supports ADEA's role as the voice of dental education. My name is Dr. Eugene Anderson. I'm the ADEA Chief Policy Officer and Managing Vice President. To learn more about the ADEA Policy Center, we encourage you to visit the ADEA website, www.adea.org, and click on the Policy tab. Joining us today for our webinar, we have our leading expert, Dr. Peter Damiano, and ADEA's own Dr. Evelyn Lucas-Perry. Before we continue with our discussion, now is an appropriate time to get an idea of just how many people are with us today. I'll turn it over to Kurt.
Thank you, Dr. Anderson. On your screen, you'll see an opportunity for you to tell us how many people are listening at your location. Either click on the colored box or the radio button, whichever would be appropriate. Notice that we have choices through 1 through 8 or more. Sites with more than 8 obviously should use that very last option of 8 or more. And Dr. Anderson, we'll give everyone just a few quick moments to complete this survey, and then we'll capture the results, and you can continue on with the presentation. And we'll give everyone another 5 seconds. Thanks much for your responses. And we'll go ahead and stop the poll at this point, and let me make a quick capture of that information. And with that, we'll move on to the presentation.
Thank you, Kurt. So we just heard from Dr. Damiano about the ACA provisions related to dental care. Now, let's hear about how the ACA is affecting dental education. For this, let's turn to ADEA's very own Dr. Evelyn Lucas-Perry.
Thank you, Dr. Anderson. And I just wanted to discuss the impact of the ACA on dental education. And the main thing that the ACA does with dental education is that it authorizes the Department of Health and Human Services to make grants to academic dental institutions for dental training programs. So this first happened in 2010, and the ACA funded predoctoral training programs in general dentistry, pediatric, public health dentistry, and dental hygiene. So when it comes to public health dentistry, it allows dental students and dental hygiene students to be able to receive their master's in public health from an accredited institution. It also provides funding for dental residents and practicing dentists. And lastly, the ACA does provide training in primary care for predoctoral programs and also expands faculty capacity through traineeships and fellowships, grants for faculty development, and it also has a faculty loan repayment assistance program. One thing that our audience members might want to know is that actually yesterday, the U.S. Department of Health and Human Services just released an announcement for a funding cycle for the predoctoral training program in general, pediatric, and public health dentistry and dental hygiene. And we've actually included this as an attachment, and Dr. Anderson will get into the details of how you can access the documents that we have uploaded. But really, this is another example of how the ACA has greatly impacted and expanded dental training in the United States. The application, again, the funding cycle was just released in December 8th, yesterday, and the due date will be February 2nd. The other thing that the ACA does is that it increases the number of primary care residents and dentists that are trained in community-based settings, and that's through what's called the Teaching Health Center Graduate Medical Education Program. So in 2010, it was a 5-year initiative, and $230 million were allocated to this program. Also, the Centers for Excellence program has received increased funding increased funding under the ACA. The Centers of Excellence are grants that help health professional schools improve their resources and curricula as they relate to minority health issues. Additionally, they also serve as centers for the recruitment, training, and retention of underrepresented minorities, and including students and faculty. Lastly, because of the ACA, $283 million in 2014 alone was allocated and invested into the National Health Service Corps. This increases access to primary care services. So the National Health Service Corps strengthens the U.S. primary care workforce by providing loan repayment programs and scholarships to primary care clinicians, including dentists, in exchange for working in communities that need care the most. And that's what we usually term as dental health professional shortage areas. One thing that I'd like to ask Dr. Anderson, if you'd allow me, is, I've talked generally about the impact of the ACA on dental education, but I think our expert, Dr. Damiano, would actually be able to give some insight of how it's impacted academic dental schools individually. So, Dr. Damiano, can you please speak on that?
Sure. I think there's two aspects that could be impacting dental schools and dental schools should be thinking about. One is just the practical, what's the impact on the clinics and the people that are going to be coming in, particularly in states where you've got a Medicaid expansion or you've got people that are gaining private insurance. And some of the challenge might be that the private insurance is not a type that the school is familiar with or has been very present in the state previously, and so the business office is going to have to deal with that. In Iowa, with this dental wellness plan, our clinics have had to make huge adjustments because of that earned benefit model and how to incorporate that into both the billing process, how to incorporate these clinical risk assessments and getting those done as a large entity, as well as just how do you provide the care, because it's different than what we teach our students. Then I think the other is just what we have to do to be able to teach our students about these changes that are going on in the delivery system. And I do that kind of teaching both in our College of Dentistry here, but also in the College of Medicine and Nursing and some others. And they don't, on the medical side, in many places, they don't get very much of that. But I think it's very important that our dental students have some understanding about this changing landscape in which they're going to be going out into, and that they understand, again, the pieces and parts of this so that they don't have a knee-jerk, reaction to whether this is good or bad, but really understand what it is, what are the implications for them. And then when they get into practice, they'll really be able to make some informed decisions about network participation or, other kinds of things that are happening.
Thank you, Dr. Damiano, and thank you, Dr. Lucas Perry. Now, there certainly has been a lot of speculation about what to expect come 2015. We just had a midterm elections, and the Republicans took control of the Senate, which gives them full control of Congress. So some of our participants are already throwing out this particular question, which is what happens when the new Congress is sworn in. So to that, I want to turn back to Dr. Damiano. What do you expect these election results may mean for the future of the ACA?
Well, and Eugene, you put it well. This is speculation. Nobody obviously knows. There are things that are being talked about as more or less likely. And the Public Policy Center here, we work very hard to be nonpartisan and work with both sides. So the discussion we're going to be having, even though it touches on politics, really don't want this to be viewed as political. But there are going to be significant changes because of the elections and other things that are happening at both the federal as well as at the state level, and then with the presidential election as well. We know at the federal level that the Senate has switched back to the Republicans, and that's been a buffer for some of the changes that the House has wanted to make in the past about the Affordable Care Act. They're, in terms of what people are expecting because of that, it's going to be, everything from some sort of a repeal vote, which is probably going to be more symbolic because of the presidential veto that would happen with that. And there's really no agreement on what a comprehensive replacement would be going on. But others are saying that there's going to be more oversight hearings. The House has been doing a lot of that in the past. Tomorrow, in fact, Professor Gruber from MIT, who had some comments that went viral about the formation of the ACA, he'll be called in front of the Congress along with some people from Department of Health and Human Services. And so you probably will be seeing more of those kinds of things. With the House, you're going to have similar, the majority is going to change even to a larger extent towards Republicans in the House. And so the discussions about what that's going to mean, again, repeal votes, I'm sure those will come up because they did many times in the last session. But in terms of where this will happen, we're going to talk a little bit about some of the speculation with the Supreme Court. And that's where, depending on how the Supreme Court case rules out, some of this could get thrown back into the Congress, and it'd be very interesting to see where those discussions go. But there are some things that there could be some bipartisan agreement on that could have some significant change to the Affordable Care Act. One of those that's being talked about is a medical device tax. And there has been some look at that in the past already, and that did have bipartisan support in the Senate. And this is a 2.3% excise tax on medical devices, and actually dental crowns are included in that. But if that were to be eliminated, it would cut about $29 billion over 10 years, and that money would have to be replaced by something. So that would take a big dent into the Affordable Care Act and something that, could possibly happen. You've got others that are going to be looking at the employer mandate component of this. And even though 95% of large employers already do offer coverage, it's the lower income ones and lower income employers, the low wage jobs where they don't for the most part. And if they were to eliminate the employer mandate, estimates are that it could increase the uninsured from 200 to 500,000 and actually cost the federal government between 46 and 130 million because then you'd be picking up more people potentially in Medicaid or with some sort of a subsidy. You may not have had it before. Some employers are also talking about, or the Congress is talking about changing it so that the employer mandate would go from 30, it's actually 30 to 40 hours a week, not 30 to 40 employees. Hours per week in terms of when it would kick in, and that would obviously then affect a lot. There's some things about insurer risk protection that could be targeted. There was a 3-year startup program to protect the insurer's risks, and so then if the insurers don't feel as well protected, they might drop out of the health insurance market based on the private side. Potentially some repeal of individual mandate, but that's probably not as likely going to happen. Changes also at the governor level, though, in terms of what Medicaid expansion might mean. There were 5 states that, depending on how the election went, thought might move in the direction of a Medicaid expansion. That's probably less likely right now. And at the state level, in terms of the state legislature, the support for the ACA obviously varies. One interesting one to keep an eye on is in Arkansas, where they were the only state that had an entire Medicaid expansion model, and their old Medicaid expansion for adults only went to 13% of poverty, now goes from 13 to, I believe, 133%. That's purchasing subsidized plans, actually it'll be free plans for people in that as a Medicaid expansion from the health insurance marketplace. But there were 4 Republicans that gained seats in the Senate, I believe it was in Arkansas in this last election, all campaigning against the Affordable Care Act. They have to take a look at that every year, so there's a chance that could be changed. If you start seeing those kinds of changes, because so much of this is going on at the state level, could also affect the implementation, which is going to be really important to watch. In terms of the Supreme Court case, again, I'm not a constitutional lawyer. I follow this from a policy perspective and have an interest. But the language in the bill is inconsistent, and that's what this challenge is about, that it wasn't clear that the subsidy should be allowed, to some people's belief, to those who purchase insurance outside of a state marketplace. Now, the people who wrote the bills and the chair of the Senate said that that was their intent, but the Supreme Court is obviously going to be ruling on that, and a lot will depend on the breadth of that ruling, whether it be very narrow, whether it be broad. If that doesn't happen, if they say, yes, you have to do it through a state exchange, and that would mean the IRS would stop paying subsidies to those in the 28 states that use the federal marketplace, then a lot of those lower income people that got the subsidy, they would probably fall below this 8% threshold on which the individual mandate kicks in. So if you can demonstrate that the cost would be more than 8%, then you don't have to purchase insurance or be a part of the individual mandate. That actually increases the cost of the federal government significantly, and also decreases the how evenly spread the risk pool is in those exchanges, because more likely the lower income people who have significant health problems will be the ones that will continue to purchase it, and those who are healthier at the time won't. And that's expected. That RAND did a study that it would increase the overall premiums about 43%. So it's going to be very interesting to see, how this plays out. Many opponents of the Affordable Care Act are hoping this ruling will go in this direction. But what will be interesting, if that does happen, what the alternative might be, because if you do have in the neighborhood of 13 million people by 2016 that could end up losing some coverage because of this, it's always harder to take something away from people, and what would be proposed to potentially replace it. And so that's going to be sort of an interesting thing to watch here.
So, Dr. Damiano, as our time winds down, we want to give our participants some additional time to post some questions. So let me ask you, from your perspective, as you think about what you've seen, what you've studied over the past few years of following this, moving forward, what type of changes would you like to see made to the Affordable Care Act relative to oral health care?
Well, it obviously would have been nice if the mandate for the essential health benefit for pediatric dental services would have been comprehensive. There were some actual very practical reasons why they made the decision not to say you had to get it, because they didn't have the ability to track private dental plans as well as medical, and it was become very difficult to try to make that mandatory. But I think that is something that obviously it would be nice to see. The delivery system changes that are happening are just huge, and I'm not sure that as much as the ACA is sort of being credited or blamed, a lot of these things are being driven by the private sector right now, both on the delivery system side and private insurance companies. And so it's really not a change that I'd like to see in the ACA, but I think it's really important that we continue to think about how do we manage populations of people, how do we deal with the high cost, high utilizers with multiple chronic health conditions, how does oral health play into that as be a part of the health home and interact effectively with the medical providers, with the pharmacies, with, we do this intermittently right now, but I think working on ways, and we're developing a concept for measuring a primary care or patient-centered dental home to match what's there in the patient-centered medical home as a way of looking at that integration of services.
All right. Dr. Damiano, one of our participants wants to clarify, are preventative dental services covered at no cost?
Yes, and that was a change across the Affordable Care Act about an increase in preventive service coverage at no cost on the medical side, and including Medicare, where there is coverage on those plans, for children in particular. Yes, those are covered at no cost, is my understanding. And in Medicaid side, where their EPSDT does mandate it, it's also at no cost.
Okay, and what about teledentistry? Is this something that is supported by the ACA in any way?
Not that I'm aware of specifically. But when we think about the patient-centered dental home, and the models for that can take many different forms, and I think there's some models in California that are going on with a virtual dental home and teledentistry kinds of things, and I think, there's opportunities for incorporating that in. I'm not sure which aspects of the ACA specifically that would be, a component of, but I think these delivery system changes we're talking about, there's definitely room for that.
Okay. And what about this goal to reduce emergency room visits? Can you explain, you touched on it earlier, but just can you explain for us how does the policy, the Act, envision that occurring?
Well, there's nothing specifically in the Act that addresses that, but where I think this is starting to get some play is when you think about an accountable care arrangement, and that the people that are coming into the emergency department, even with insurance now, you're going to be seeing as a cost rather than a revenue. We've talked about emergency room reduction on the medical and dental side for a long time, but one of the real challenges is people are coming into the emergency department with insurance, they're actually a benefit to the hospital. And in many places, the emergency department is where most of the admittance to the inpatient wards go through. And so it becomes a little bit more complex. So on the dental emergency diversion, or however you want to term that, if an accountable care arrangement determines that somebody that comes in with a dental problem, and we all know that it's non-definitive care when they come in, so it's not a good thing, because they're going to get a prescription for pain meds and an antibiotic and hopefully can fill them both, but nothing definitive, that they can get referred for more definitive care. So that's the positive, but I think the incentive in the system is then if the accountable care arrangement believes that that's going to improve their cost and their bottom line, that they will look for arrangements to do this. Again, there's the range of a diversion where you contract somebody out, so somebody comes in and refer them over. Hennepin County Hospital in Minneapolis has an interesting model where they've really incorporated a dental chair from a different place within the facility much more into the emergency department, so it's right there.
All right. Dr. Damiano, we have time for one final quick question, and one of our participants wants to know, does the ACA improve access for specialized oral health services?
It's going to depend from an insurance coverage perspective. For children, yes, that gained it either through a standalone plan or through Medicaid, for the most part, yes. For adults, it's going to depend on if they purchase a standalone dental plan, what the types of coverage is, because it's still going to vary in terms of copayment rates and coverage and coinsurance rates and those kinds of things. But you would hope that for the people that have gained insurance, that it would improve their financial access. Now, again, that's not necessarily access because of geographic reasons and other barriers that we all know exist from a access to care perspective.
Well, thank you, Dr. Damiano, for leading our discussion today, and thank you to Dr. Evelyn Lucas-Perry for providing additional expertise. I want to thank all of our participants today, and before I turn it over to Kurt for final comments regarding evaluation and how to get those valued CE, I want to remind everyone of an important ADEA resource that provides a lot of information on this topic and many others. ADEA's Advocacy and Government Relations portfolio, which is led by Ms. Yvonne Knight, has developed numerous resources on what is happening at the federal and state level. We have 2 newsletters that are sent out monthly, and you can find these resources at our website, adea.org, under the Policy tab. We have the Washington update and the state update that you can download and view, and also sign up to receive monthly from us. I want to thank everyone for participating with us today. We are closing out this year, and we will be back with a new set of topics in late January. So we'll be sending out emails to all of our past participants and members in a few weeks, letting you know about the topics that we will be looking at in the coming year. Thank you all very much, and over to you, Kurt.
Thank you, Dr. Anderson, and that does conclude today's presentation to the ACA Through a Post-Election Lens, brought to you by ADEA and presented by Dr. Peter Damiano. Your ADEA host was Eugene Anderson, with additional support from Evelyn Lucas Perry. We do hope you enjoyed the presentation. CE is available for this presentation. To obtain CE, enter your name in the site roster. You'll receive an automated email with a link to the evaluation and a link to the certificate manager. Complete the evaluation form, and then you may retrieve your certificate. You'll be redirected to the site roster as we end this presentation for your convenience. And be sure to follow ADEA Web on Twitter to join that conversation, and we're using the hashtag ACA post-election for this presentation. You can find the recording and presentation of this program at www.adea.org/ACA post-election, which will be posted 1 week from today. Today's program is copyrighted in 2014 by the American Dental Education Association, all rights reserved.